Chapter now. It's our last chapter we'll discuss before we test again. So considering we're on the tail end of the semester, I thought good idea to kind of do a quick look forward at what's happening in the rest of the semester. So we are in week 10. This is actually our last session this week. We do not have a lab this Friday. No lab this Friday. I think the following Friday is an open lab. I'll talk more about that next week. But today we'll do chapter 42. Monday next week, November the 3rd, we'll finish the second part of chapter 42. And then Wednesday of next week, the 5th, we test over chapters 40, 41, and 42. The weeks after, we'll do chapters 43 and chapters 44. Those two chapters will knock out lung expansion therapy as well as airway clearance therapy. That's not suctioning, that's all the different devices and things we could use to help kind of jostle the patient, mobilize mucus to help the patient be able to expectorate more. Also during this time, don't have a concrete date yet, but during these times, I've invited the folks from the FSRC to come out. They've been after me since the semester started, wanting to come out and talk to you guys. And I said, hold off, partly because I know, at least in recent years, we've had class cancellations because of weather, etc. So not knowing how our schedule would play out, I think we're pretty safe now. So I told them they're welcome to come on out. So we're working out dates, but at some point around this time, prior to Thanksgiving, I'll have the folks from FSRC come out and do a little talk. Week 14, I left open. Again, that was always my emergency day. If things needed to slide down, that would have filled in. Hopefully, knock on wood, things go well. That's the week of Thanksgiving, so hopefully I can say, okay, no reason to come out that Monday, because Wednesday we're closed anyways. And then the last week, that Monday, we'll do a final exam review, because again, this is going to be a cumulative final where we're going to cover everything. Now notice the last chapter we will test on is the one you guys are about to take next week. So chapters 43 and 44 will be part of the final exam. And like I said, on that date, I'll talk more about what you need to look forward to come that final exam. But I'll go ahead and share this information with you guys. When it comes to the final exam, half of the final exam are coming from these two chapters. The other half, everything else. So when people always say, well, John, if you're reviewing the final here, that only gives me a couple of days to study for it. Okay, that's all the stuff in the past that we've already talked about that technically I don't have to give you a review for, but it's the stuff from the past. And I will offer some helpful hints on this day. Hey, if I were you to narrow your focus, narrow your scope, I would focus on these things to review. But meanwhile, prior to that review date, and granted, I know Thanksgiving is going to be occurring, but there's also some days before Thanksgiving, where you don't have any school obligations. You can continue to review the chapters 43 and 44 that we will be discussing on those dates. All right?
The final was about 45 questions?
No, the final will be, and I haven't made it yet, so I can't give you a specific number, but generally the final could be anywhere from maybe 50 to 60 questions. So I give you a few more questions, obviously, because I know half of them are going to come from here. Okay? Right, yeah. No, because you also have another final that same day, right? No. Oh, man, think about that.
Why are you doing that to us?
So I didn't want to make you take two 100-question final exams. So like I said, maybe 50, 60 questions. I'll know more when we get closer to this time, and I'll be able to fill you in specifically. And what I generally try to do, and again, it's for a purpose, one test maybe 60 questions, the other test maybe 55, or one test 60, one test 65, just because I hate to give the same number of questions. And again, it would never be my intention to do this. What if I had all the Scantrons and I mixed them up? And so I can see just number of questions, oh, that's this final versus this set of questions is this other final, which I will stress to you on that day. Hey, make sure you label this is the fundamentals final or this is cardiopulmonary A&P final, just in case. Again, it would never be my intention to mix them up. grading them separately, but in case that was to happen, I set them on the desk and the whole file comes spilling out with everything mixing up.
It's for everyone.
Right, yeah. Good idea. Right. All right, so chapter 42, the one we're talking about today, is on medical gas therapy. Specifically, and today really is our emphasis is talking about delivering oxygen. Okay, we talked about oxygen as a medical gas earlier in the previous chapter, but this is all about oxygen. And so what I will simply call the power of oxygen, the power of oxygen that we're going to deliver through some of these different devices. But before I go over the devices, did you know that oxygen is such an important element, such an important factor, that it's found in many different products, such as things to keep your teeth clean, things to keep your, I can't even read it, immune system, energy level up, things to clean products, things to keep your skin nice and well oxygenated. You may wonder why my boyish good looks here, from that cream that I rub oxygen in. To make your nails grow longer, right? All these things. There's oxygen bars, right? You can actually go and take some oxygen. Yes, it is flavored. I don't know if you can read this. Peppermint stick, pina colada, citrus zing, and my personal favorite, the kiss me all over flavors. Which, if you go to an oxygen bar and you sit at the counter, right? You sit at the counter like these people are sitting at the counter. These are like bubble humidifiers, right? They hand you your own, they open it from the package, your own clean nasal cannula, and they hook you up to the same vat of liquid that everybody else was breathing through. Enjoy yourself when you use that oxygen bar, right? Granted, they're not exhaling back into the humidifier, but I know I would never use the same humidifier on different patients, right?
Isn't like oxygen a drug? Like doesn't a physician
Absolutely,
prescribe that?
absolutely. Then how can you can walk through Las Vegas, because this is in Vegas. Walk through Las Vegas and, hey, come here, sit down, let me show you something. Last time I was in Vegas, there with some friends, you know, friends who were actually respiratory therapists.
Oh, so is this
I'm
where you
gonna
got
try
this
it.
picture?
I'm gonna try it. Yeah, I didn't give you the picture of my friends on this, but let's try it. And they asked me, "Drive out." I'm like, no, I'm good. I'll watch them. Yeah, to make a buck. And I want to say, was it 10 minutes for $15 or something like that? Like, dang, I got some tanks in the lab. You want to make some bucks this weekend? We'll go to the beach. We'll open up a booth or table there and make some money. All right, but you're right. Oxygen is a drug. It is a drug. It doesn't need to be prescribed by a physician. How they get away with it, I have no idea. Oxygen is on the name of magazines. It's in books, and I don't mean your respiratory books. I mean flood your body with oxygen. Just did it, thank you. I would love to be known as Mr. Oxygen, Ed McCabe. Okay, I don't know who this guy is, but you know, flood your body with oxygen. Oxygen's such an important thing that it comes in aerosol cans. You're on a table, you can inhale this. What is this one? OxyFlush, cellular cleansing. I don't know even what that means, but okay. And even on the name of buses, oxygen is that important. Obviously, all this is just a joke that I'm sharing with you guys. And I actually have a can of this. It's sitting on my desk at home. It feels light as a feather. One day I'm going to open it. I'm going to inhale it just to see what it feels like, if anything. And it even says, this feels extremely light. It is just oxygen that's in there. And I'm sure after about 3 or 4 puffs of it, it's going to be emptied and gone. What good is that going to do for me, taking a couple of hits of oxygen? I have no idea. If I was sick and needed O2, I need more than just, that's it, that's gone. I'm going to need more than that. So I find these always fascinating and interesting. And somebody, yes, is making me, that looks like hairspray. Okay, some 21% oxygen, great, because we just don't have enough in here right now. Way to make a buck.
They sell it all over Denver.
Yeah, I was about to say.
They're all over Denver.
Right. And I get it that elevation in the lower barometric pressure. All right, we know this. Human beings can live for days without water, weeks without food, but without oxygen, biological death will occur beginning within 3 minutes.
All right, it's our timer.
And after about 6 minutes, we will have complete, irreversible death at that point. So again, water, food, super important, but we can go a lot longer without that than we can oxygen. I'm stealing this quote from the American Lung Association. When you can't breathe, nothing else matters. That should be the catchphrase of every respiratory therapist. But we're worried about the kidneys and we're about blood pressure. But if you can't breathe, nothing else matters, right? All right, so let's talk about oxygen therapy. The goal of oxygen therapy should be to maintain adequate tissue oxygenation while minimizing the work of the heart, cardiopulmonary workload. The technical goals of oxygen, and you may have been exposed to these, may be worded a little bit differently than what the Egan textbook does. I left it the way the Egan textbook writes it out. Number one, to correct documented or suspected acute hypoxemia. Number two, decrease symptoms associated with hypoxemia. You may hear that referenced as decrease the work of breathing. The last one, decrease the workload hypoxemia imposes on the cardiopulmonary system. You may recognize that one as being decrease in the workload on the heart. Okay? Those are the fundamental basic goals of oxygen therapy. Which one is the most easily documented goal of the three? Which one do you think would be the most easily documented? Number one, number two, or number three? Two? Okay. Three? One? Okay, good. We have the smattering. Number one is the easiest one to document. The others are subjective based on the patient's own personal sensations of symptoms, noticing that my breathing is more difficult or the workload on my heart is more difficult. How do I know if somebody has hypoxemia? We may be able to get a blood gas and get a number. And that number can tell us, yes, the patient has hypoxemia, period. There's no subjective feelings, anything about it. It is what it is. The number is the number. So of the three, the first one is the most easily documented number to define a goal of oxygen therapy. All right, this slide's kind of busy, so please forgive me on this. Assessing an individual's needs for oxygen could be laboratory data like an arterial blood gas. We can actually measure and see what the partial pressure of oxygen is in the bloodstream, or how saturated the hemoglobin is with oxygen. Again, laboratory stuff. We'll get into this a little bit more today in the second class when we start talking about blood gas interpretation. This is not necessarily a hard and fast rule per se, but commonly used thresholds for hypoxemia as far as the administration of oxygen therapy could be PO2s that are really on the low side of normal, 55 to 60, with oxygen saturation somewhere between 87 and 90%. Okay, it's not a rule. Those are not specific rule numbers. They're definitely abnormal, but the textbook mentions those as clear indications that somebody needs oxygen. Again, because these are fairly low numbers, okay? The second bullet point here about a specific clinical issue or condition. Again, patients we know that have hypoxemia, patients that have carbon monoxide poisoning, of course, they're gonna need oxygen. I might not necessarily need any numbers to back me up there. I know they've been pulled out of a fire, they've been inhaling lots of carbon monoxide. I may immediately put them oxygen just because of their presentation. Post-operative patients that still may be under the effects of anesthesia. You know, they're just not waking up just yet. Maybe they need to have a little bit of extra oxygen on board until they do start to wake up a little bit more. Patients in shock, patients with a pulmonary embolism, trauma patients, acute myocardial infarction patients, the heart attack patients, patients during cardiopulmonary arrest. Again, those specific situations definitely can indicate oxygen therapy may be necessary in those situations. Bedside assessment stuff. And I'll go over some more than just these, but tachypnea, tachycardia. Tachypnea means fast respiratory rate, tachycardia, fast heart rate, cyanosis, obviously the bluish discoloration of the skin, overall distressed appearance, increased work of breathing, etc. Some of these signs that could indicate hypoxemia or even hypoxia, again, tachypnea, tachycardia, those are always going to be the first two indicators, the first two things to identify distress. Dyspnea, of course, the patient's color, they could be cyanotic, they could be pale, lacking color. Hypertension, hypertension means what? High blood pressure, they could be restlessness, they could have restlessness, they can have somnolence, so where they're just antsy and agitated, to somnolence where they're really sleepy, really lethargic. They could be disoriented or confused. Again, think about it. If your brain is not receiving enough oxygen, do you think you'll be a little off, a little confused, maybe not making total sense? Absolutely. I had a patient, actually it wasn't my patient, well I guess it was my patient at the time, working in an ICU. I know, and I was working night shift at the time. During the night, I kept noticing, and again, at night it's usually fairly quiet, kind of routine patient. Most of the patients are typically asleep, and we were in a small ICU. It was maybe 10, 12 beds kind of surrounding the nurse's station. But I noticed one patient's light was on basically all night long, and the patient's poor nurse was in and out of that room all night long. You know, part of the joy of being a respiratory therapist, I don't have to be that patient's beck and call 24/7 of my shift, but that poor nurse does. And so she was in this guy's room all night long. And wasn't a patient on my list. There was really no therapies I was providing to this patient. The patient wasn't not on the ventilator, wasn't on BiPAP or CPAP, anything like that. I think there was an order for oxygen therapy, but I don't remember specifically at the time what that was. But there was no breathing treatments, nothing like that. So it really wasn't a patient I was even seeing. Around 5 o'clock that morning, had done my rounds of morning blood gases. So the blood gas lab in this particular ICU was just around the corner from the unit. And I was in the ICU when one of my fellow RTs from another ICU was in the blood gas lab with me, and we were running our morning ABGs. And so we're both in the blood gas lab. He was a male, I'm a male. One of the female nurses comes running around the corner to the blood gas lab and said, "Guys, we need you now." And you could hear the concern in her voice. So we basically dropped what we were doing, we come hustling out. There was, in that small unit, there was maybe 4 nurses tops, and maybe I'm confusing one of the CNAs, but there was only one other male. One of the RNs was a male, but everybody else in there was a female, aside from myself, the respiratory therapist, and the other respiratory therapist that was in the blood gas lab with me. Again, we hustle out. My friend was ahead of me. I'm kind of tailing right behind him. And I can see, looking in the unit and through beyond the nurse's station, I could see there was a light on in one of the corner rooms. Now that room was for storage. It was a storage room. And I noticed the nurse from that one patient's room that was in and out, she's in that storage room, and there was a patient and a patient down in the doorway of the storage room. And I could see her, and in that storage room, I know there's only one way in, one way out. There's no back door to get out of that storage room, but she's in the storage room, and the patient who was in that one room with the light on all night long was in the doorway. And he had an E-cylinder in his hand up over his head. And so as we're going around the corner, now I understand why she was kind of hollering for us, "We need you now." So we're kind of running around the corner. The male RN was grabbing hold of that cylinder so this guy wouldn't throw it or drop it or do whatever with it. He gets the cylinder away from him, and he's grabbing the patient. Again, all this is as we're kind of running around the corner. Therapist in front of me kind of joins in, and they're bringing this guy down. Well, being the last guy on the play, what do? Anybody who's ever played football before? What did I do?
Dive in the pile.
I jumped on the pile. Woo! You know, and keeping everything down. Long story short, and the patient was taller than me. He's probably a good 6'1", 6'2". As we have him on the ground, again, not my job, mind you, not my job. He's apologizing. I'm sorry. And we're like, sir, it's okay. Just relax. Well, then security shows up. The gentleman was probably a good 30 years older than I was at the time, about 85 pounds soaking wet. Looks like you guys got everything under control. And he walks out like, buddy, I didn't sign up for this. This is not my job. Anyways, the patient was apologizing. I'm like, it's okay, let's just get you back to your room and get you settled.
Get you strapped down.
Yeah, get you tied down and make sure you're not hurting anybody. But again, apologizing the whole time. Well, the physician that was on call at that time, of course, gets called. She comes over, looks at the patient, and says, let's get a blood gas.
God.
My friend, fellow RT, he was working a different ICU that day. Who was working this ICU? Me, so who has to get the blood gas? My friend goes, all right, John, well, I'll see you later. Thanks, great. All right, so I got to stick this guy who's confused, who was combative, he's cylinder up over his head. I don't know what his intentions were. I can only assume that the poor nurse that was taking care of him all night long, he was unleashing his wrath on her. But thankfully, we stopped that from happening. And so we get over to the room. He's in the chair. He's still apologizing. I know I have to stick him for a blood gas, and I know this guy's a little off. And so I'm telling him what I'm about to do. Please hold real still for me. I got the male nurse who was there. Hold his arm just to make sure he doesn't start throwing punches at me or anything the second this breaks the skin, because it's going to be uncomfortable. It's going to hurt. Whole time I'm telling him, all right, you're going to feel a pinch. It's going to be uncomfortable. Okay. He didn't move a muscle. He was perfect. Get his blood gas. His PO2 was in the 40s, which is significantly low. O2 sats in the low 80s, high 70s, low 80s, really, really bad. Well, what was his problem? He wasn't wearing his oxygen that he was supposed to have been wearing all night long. And the whole night he wasn't wearing it. The whole night he was telling the nurse, please call my wife, please call my wife. The nurse didn't want to call the wife because it was, midnight, 1 o'clock, 2 o'clock in the morning. Didn't want to wake up and worry the wife. He said, we'll call her in the morning. And I guess at one point
She wasn't aware that he
just
needed
had
oxygen?
enough. Well, she had to have, because he wouldn't keep it on. So obviously reporting back his blood gas numbers and his significant hypoxia that he had. And every time I say this, I can't think of him. To this day, I still think of him and that confusion he must have experienced. I don't know where he thought he was, who we thought we were, whether he was in a prison and we were guards guarding him. I don't know. I don't know what was in his mindset, but he definitely was disoriented and definitely was confused. Simply because he didn't have enough oxygen in his bloodstream, getting oxygen to his brain. Headaches, blurred vision, again, probably my guy here. Impaired judgment, again, trying to hurt people that are actually there to help him. Lassitude, what the hell does that mean? Lack of energy. And then worst case, coma. All right, all signs of hypoxia or hypoxemia here. Now, of course, there could be other things that could occur that could lead to the similar symptoms, but this definitely could be an example of someone just lacking enough oxygen. As far as clinical practice guidelines and contraindications to oxygen therapy, really isn't one. All right, certain situations, we'll talk about hazards and things like that, so certain situations we'll definitely be aware of, but there is no specific contraindication for oxygen therapy. Precautions or hazards of oxygen therapy. Of course, we need to know these and be well aware of what are some issues that could occur by placing a patient on oxygen therapy and be able to identify or recognize them if they happen. No doubt that oxygen saves lives, but it is a potent drug. Probably one of the most prescribed drugs, medications out there. Oxygen is a medication. We're giving oxygen more than 21%. Yes, that is a medication. And again, common hazards, oxygen toxicity, what they're wanting us to change, and I'm a big fan of that word combination, O2 toxicity. It's pretty easy, rolls off the tongue. They're trying to get us to use hyperoxic acute lung injury instead as the new term. No, okay. I'm still, and you're going to hear me say it's O2 toxicity. We'll go over what acute lung injury can happen. I bet you they like us to use this word because it's more descriptive of what happens. Depression of ventilation. Oxygen can depress your ability to ventilate. Yes, it can. We'll talk about that. Retinopathy of prematurity. You may have already been introduced to that. What is that?
When babies get too much oxygen.
Blindness leads to blindness in the neonatal patient population world. Absorption atelectasis, and of course the fire hazard. All right, so oxygen toxicity or hyperoxic acute lung injury. So hyperoxia means extra oxygen. Technically been defined as having a PO2 greater than 300. Now, anybody remember what's a normal arterial oxygen concentration or oxygen level?
80.
About 100. There's a range of 80 to 100, but for you and I would say ours is probably about 100. Anything over 300 by definition is hyperoxia. But studies show it becomes important not when it gets necessarily 300, but 150. So again, higher than normal. And again, how do I get someone's PO2 higher than normal? Giving them oxygen, giving them supplemental O2. So the two primary factors that lead to oxygen toxicity. The higher the P little AO2 is, so putting more oxygen in the bloodstream, and how long they are exposed to this higher concentration of oxygen. Again, what could cause this to occur? Us giving a patient a higher FiO2, a higher oxygen concentration. Now, again, the acute lung injury that happens, okay? And for right now, I want you guys to remember it can cause lung damage, lung injury, okay? For now, it can cause lung damage, giving them too much oxygen. Exposure to the higher partial pressures of oxygen, the higher the FiO2, can damage the capillary endothelium, leading to interstitial edema, which thickens the alveolar capillary membrane. Now, if you remember from discussion a while back, the thicker that alveolar capillary membrane, it's going to decrease gas diffusion, right? It's just creating a bigger gap, a bigger space, a thicker membrane for oxygen to try to diffuse into. So again, that's part of the lung damage that's occurring. As it processes, type 1 alveolar cells are destroyed. What makes up the majority of the surface of the alveolus? Type 1 or type 2? Type 1 make up the majority of the surface. Type 2 that provides surfactant. As the fluid builds up, it lowers VQ ratios, that's ventilation to perfusion ratios, leads to shunting, blood going past non or underventilated alveoli, and hypoxemia. Again, what were we doing with this in the first place? We were giving the patient oxygen, and what are we ultimately causing? Hypoxemia? Doesn't that sound kind of opposite of what we're really doing here? So, as the lung injury worsens, I'm sorry.
What was the VQ? What was the
Ventilation
Q?
perfusion. Ventilation perfusion ratios. Lowering ventilation to perfusion. So as lung injury worsens, blood oxygen levels deteriorate, get even lower. This progressive hypoxemia is managed by doing what? Giving them more O2 to try to combat the hypoxemia, hence the circle that we're seeing here. So if I have someone with low oxygen in the bloodstream, what do we give them? More oxygen, right? We increase the FiO2. That leads to oxygen toxicity, which leads to the lung damage. Lung damage leads to hypoxemia. What do we do for that? Give them even more oxygen, and this cycle continues to happen. All right, so we're chasing our tail trying to fix the problem with hypoxemia by giving them more oxygen, leading to more damage. So, how do we prevent that from happening? How do we avoid this from happening? Never give the patient too much oxygen. Give them what they need, but let's not give them too much oxygen. There's no reason for us to go into, let's just say let's just pretend we're walking to the hospital today and all we're doing is checking pulse oximetry saturations. Let's say that's all we're doing. And I'm going room to room checking O2 sats, okay? Checking O2 sats. And I'm seeing a lot of normal patients. 95, 98%, 100%, 100%, 100%, 99%, 98%. That last patient that had a saturation of 98% was on a 100% non-rebreather. 100% oxygen. Do they really need that? Or, and again, not knowing anything else about the patient. They just have a great saturation. All right, when are we going to discuss lowering the FiO2 that patient is receiving? Are you just going to leave them? Let somebody on the next shift deal with that. You know, that's where we're leaving them on oxygen for such longer periods of time. So even with all of this, even knowing these hazards and potential complications of having oxygen, I will never, never withhold oxygen from a patient. Okay, if a patient needs O2, give them O2. Okay, don't be worried that, well, I don't want to cause this, I don't want to cause that. Yeah, those are things we need to concern ourselves with. But if we feel this patient is best going to be treated right now by giving them higher concentrations of oxygen, then of course we will do it. We will do it. If there's some issues that develop, okay, hopefully we can deal with those later. But I'm never going to deprive a patient of oxygen. All right? I'm sorry, say that again.
Because you know the consequence right there.
Absolutely. With not enough oxygen, of course, the patient might not survive. All right, so I'll be more than happy to give them extra O2. Right now, that may be temporary. Maybe in the next 15, 20 minutes, we can change it, lower the FiO2, and avoid any potential complications.
Can you explain shunting real quick?
All right, shunting. If I have alveoli that are not being properly ventilated and the blood shunts past these non or underventilated alveoli, it's a type of VQ mismatch, ventilation to perfusion
So it's ventilated,
mismatch.
but it's not perfusing.
It's perfusing, not being adequately ventilated.
Okay.
Again, partly from this toxicity, from this damage that's occurring.
So it's just like bypassing.
Yes, it's shunting non or underventilated alveoli. We have a whole talk in a couple of weeks in the cardiopulmonary class on VQ mismatching and shunting. We'll get into that a lot more.
So, so I had to look up like how oxygen bars were legal. Just cause like it was kind of running
And it's
my mind
gonna,
a little bit.
and it's going to be different in
So
every
I had
state
to-
too,
I had to
right?
like look it up, but it just says that they don't use compressed oxygen tanks, and they have to label it as recreational and not medical.
Of course.
And then they have to sign like consents, limit time, and then with the FDA, it says that they've chosen not to touch it, and
Yeah.
they just leave it up to state and local boards
Right.
to handle the
Basically like
enforcement.
marijuana.
Correct. Right.
So,
Yep.
Compressed air.
All right, so
they just use like the oxygen.
exposure time.
Cylinders.
All right, exposure time. The longer the patient's exposed to these higher concentrations of oxygen, the worse things can occur. Like I said, I'm not going to deprive someone of oxygen if they need it. Hopefully they need it for a short period of time. Meanwhile, we can treat whatever is going on with them, hopefully fix that with whatever's going on with them so they don't have to be on that high FiO2 for an extended period of time. But the goal should be to use the lowest possible FiO2, the lowest possible oxygen concentration that provides adequate tissue oxygenation. This was a rule of thumb from the textbook, and I like it because it's a good kind of mindset to go by. Limit patients' exposure to 100% oxygen to less than 24 hours whenever possible. Okay, whenever possible. High FiO2 is acceptable if the concentration can be decreased to maybe around 7% within a couple of days, or 50% or less within 5 days. So when we put someone on oxygen, especially the higher concentrations of oxygen, we should also be mindful, okay, When are they starting to get better so we can lower that concentration of oxygen? Get it down to a safe level, something less than 50%. But again, there's going to be those very sick patients that need higher concentrations of oxygen for a little bit longer than what this may say. All right, depression of ventilation, or what we can also just simply refer to as oxygen-induced hypoventilation. Hypoventilation means the patient's not ventilating adequately or very well. All right, this is seen when someone is breathing moderate to high concentrations of oxygen. I would say moderate's in that 50 percentile range or higher. It can cause their respiratory system, their ventilatory system to become depressed and lead to hypoventilation. Now, right now, looking around this room, I don't think any one of us would be a patient I would be concerned about this happening to. However, there is a group of patients we tend to see quite a bit that can, that can develop hypoventilation from receiving higher concentrations of oxygen. And it's not even every one of those patients. And you know who I'm talking about here, right? The COPD patient or chronic hypercapnic patient. Hypercapnia means elevated CO2. So those lung patients with normal elevated CO2 concentrations. Not every one of them, but an extremely small percentage of them may breathe off of what we call the hypoxic drive. Now, just from the other day, what's the signal that causes us to breathe or to ventilate more? CO2. That's the primary factor that controls our brain, the signal to our brain to say, ventilate more, John. CO2 level starts to rise, ventilate more. Now, we'll get into this a little bit, the whys a little bit later, but the COPD patient or the patient with chronic hypercapnia, they live already with an elevated CO2. So what happens to them is that elevated CO2 ends up becoming blunted. It doesn't cause them to ventilate more. They have some compensation because of their bicarb and their kidneys, etc. We'll get into that in due time. But their CO2 levels are normally high, higher than yours and mine. And so for those patients, what turns around to be the signal to their brain to breathe ends up being their PO2. Their O2 level ends up being the only thing that's really signaling their brain to ventilate more. They normally live with a PO2 that's already on the lower side of normal. Their PO2s are not necessarily the same PO2s yours and mine is. They normally have a lower PO2, sometimes down into the 60s, sometimes even high 50s. That turns into their signal to breathe. Okay, if their levels get to be too low, that sends a signal to them to breathe. When we give that particular patient group more oxygen, too much oxygen, we raise their PO2 levels to a level that's much higher than is necessary to send the signal for them to breathe. And how do they breathe? Their body senses, well, my PO2 isn't so low anymore, I guess I don't have to breathe. And they hypoventilate. It's not every single one of our COPD patients or chronic hypercapnic patients that breathe this way. A very small group of them. However, every time I give a COPD patient or chronic hypercapnic patient oxygen, I need to be mindful and not be over-aggressive in giving them a high oxygen concentration because of the potential to knock out their drive to breathe. And so be very careful there. It's not going to happen that often, but if it does, think how detrimental that can be to the patient. They're not going to ventilate. They're not going to breathe. And do they need a ventilator? Well, they will if we let the situation continue. Why don't we just keep their O2 levels to their normal, not to my normal, not to your normal, to their normal, and then they would never hypoventilate. So for this grouping of patients, be very careful how much oxygen you give them. I'm going to be very conservative. And whereas you're a little hypoxic, I may say, let's put you on 40%. But for them, I say, let's start on 28. Let's start at a very lower concentration because I don't want to knock out their drive to breathe. I'm not worried about you having this oxygen-induced hypoventilation because I don't believe you have COPD. I don't believe you're a chronic lung patient, chronic hypercapnic patient. Jen?
That's crazy how the body knows to like swap the signals.
It does. It does.
It's crazy.
Absolutely does. And again, if we give that patient too much oxygen, I just blunt or suppress that signal that they are normally receiving to breathe. All right, retinopathy of prematurity, also known as retrolental fibroplasia, allowing a neonate, so this is affecting babies, typically premature babies, that we give high oxygen concentrations to. High PO2s in the blood can cause retinal detachment. That in turn leads to scarring and permanent blindness for the infant. All because we did what? Gave them too much oxygen. So in the neonatal world, we are ultra conservative as far as how much O2 we give them. Infants, no, different story. Newborns, we're being very cautious with, especially premature newborns, being very careful on how much oxygen we give them. So in their patient population, we keep their PO2s less than 80, which, just so you know, this is the lower end of our normal. Our normal is 80 to 100. So for them, I even keep their PO2s less than our low range normal value. So sometimes you can see 50 to 60 in a lot of textbooks as being where you want to keep their PO2s. Even though ours, we say let's keep it around between 80 and 100.
I think that's how Stevie Wonder became blind.
It's one of those. Desmond knows. He always tells me, and I always forget which
I think he
which
told us.
artist it is. But yeah,
Well, we gotta remember because it's gonna be on the test.
because I can't remember if it's Stevie or Ray Charles. I get both of those guys
Stevie.
backwards and confused. But yes, I think that's right. All right, next one, absorption atelectasis. So a higher FiO2 level, something above 50%, will wash out the nitrogen, which normally, what percentage of nitrogen is in our lungs right now? About 78, 79%, with most of the remaining being oxygen and then a few argon and a few other trace gases. If we give a patient higher concentrations of oxygen, we wash out the nitrogen. And the nitrogen actually provides the structure, the architectural structure to keep our lungs open. And if we wash it out, guess what happens to the lung? It wants to collapse. And so that concept is known as absorption atelectasis. Again, we end up depleting the nitrogen from the lungs and the lung will collapse. This is going to be especially true, or would happen much quicker, if the patient is breathing very shallow, small tidal volumes. Maybe the patient is given sedation. Maybe using the post-op patient example from earlier. Post-operative patient still under the effects of anesthesia, they're not taking very deep breaths, and I happen to have this patient on high concentrations of oxygen. Again, their lungs not opening much anyways because they're breathing shallow, still under the effects of anesthesia or pain medicine or sedation or a central nervous system depressant medication. That will wash out the nitrogen even faster from them because again, they're already breathing shallow. I think I already mentioned those. Surgical pain, maybe they haven't been receiving pain meds, but they're hurting. They've had some sort of chest or abdominal surgery, so it's very uncomfortable to take deep breaths, so they're breathing shallow. Again, I give that patient higher concentrations of oxygen. That could easily lead to absorption atelectasis. And then of course the fire hazard, let's never forget that. There could be times physician may be doing some sort of surgical procedure at the bedside that may be in the vicinity of where your oxygen is freely flowing, whether it's from a mask or a cannula, something like that. And if they use something that requires heat, like a cauterizing agent, where the temperature gets heated to cauterize, burn skin, burn blood vessels, helps to stop bleeders sometimes, that could be the spark necessary. So in situations like that, you would have to turn off the oxygen temporarily while they're using some sort of cautery type device, because again, that could cause the flash or burn. Of course, patients that are continuing to smoke while they're wearing oxygen, that of course could lead to that fire hazard. And I can't help but this picture, I think the gentleman on the left, it's kind of a setup picture, but this is a real patient who decided to wear his cannula and smoke, and look what happened to his face. All right. This was the guy at St. Vincent's Clay that caught the ER fire. I'm kidding, I'm just making that up. But it could have been, it could have been, it could have been. Again, notice the damage that there is on his face and nares and nostrils. Bet you he won't smoke and wear his oxygen again.
Yeah, you will.
Yeah.
Hopefully he won't.
Nicotine's a hell of a-
I think, yeah, I know it is.
He'd be like, that was a fluke.
He did have a mustache, I think. But no,
Not
no
anymore.
more.
Oh, wow.
All right, so oxygen delivery systems. Now I'm going to give it to you the way the textbook presents it. The Egan textbook presents it this way, that there's 3 categories. You may have been told 2 categories, and that's fine, I trust me, I like to use the 2 categories too, but the textbook breaks it down into 3, okay? Oh no.
Oh, no.
Low flow, high flow, and to be honest, they're either going to be low flow or high flow. There's not an in-between. But the textbook groups the quote-unquote reservoir devices in here. Now, just so you know where I would put it all, I would say high flow is high flow. If it's not high flow, then it must be low flow. And I would actually group reservoir devices under that high flow grouping. And you'll see why here in just a minute.
Wait, you would put reservoir under high flow?
Under low flow.
Oh,
I'm
okay.
sorry. Under low flow.
You're
high flow is by
you're going to
itself.
low flow, but you said high flow, so I was like, what?
Don't do as I say. What I meant to say. There you go. But you have to read my mind to get that right. All right, so how they perform is based on how much oxygen can the system deliver, and does it provide an FiO2? Again, what does FiO2 stand for?
Fraction of inspired oxygen.
Fraction of inspired oxygen. The oxygen concentration, the oxygen percentage. So is the delivered oxygen, will the device, if set properly, keep the FiO2 fixed, or will it be variable? And we'll get into that discussion today as well as next week on Monday. All right, so this is the description for high flow, low flow, and even the reservoir devices the chapter presents. So these wavy lines represents the patient's own inspiration and expiratory flows. Inspiratory, expiratory flow. If we provide a device that is high flow, by definition, low flow. Low flow. I'm not talking about high flow devices today, so you wonder why, because I'll sit there and butcher them back and forth. Low flow devices, I apologize. Low flow devices will provide only a part of the patient's inspiratory flow needs. Only a part. High flow devices meet or exceed the patient's inspiratory flow needs. So this represents inspiratory flow. Inspiratory flow, expiratory flow. A low flow device will provide only a part. So what's in the shaded area represents me, the patient, pulling in room air, diluting the oxygen that the device is providing. Okay, so low flow device, from here to here is where the oxygen is being provided to the patient. But when the patient continues to breathe in, up here, they're breathing in room air, 21% oxygen, which is mixing with the oxygen we're providing from our device. That's why low flow devices provide variable FiO2s. You can see in this next breath, look how much more the patient breathed in, how much more room air the patient breathed in with this device. Their FiO2 being provided was probably less with this breath than it was here, because they're pulling in more 21% oxygen to mix with the device. This next breath, they took a pretty shallow breath. They hardly pulled in any room air. That basically they breathed in just what the oxygen device provided. Their FiO2 here was probably a lot higher than it was on that previous breath. And you could see the breath could change every time we breathe. It's not always necessarily going to be the same or consistent. That's why a low flow device provides only a part of the patient's inspiratory flow needs and provides a variable FiO2. Whereas a high flow device, if from this point to this point is the oxygen from the device, doesn't matter if the patient breathes in shallow or deeper, that device, if set properly, is providing all of the flow the patient needs, meets or exceeds the patient's inspiratory flow needs. That, by definition, is a high flow device. It provides then a fixed FiO2. An FiO2 that's going to do what? It's never going to change. The FiO2 with the low flow devices can vary breath to breath. But a high flow device, it's going to be fixed. It's going to be locked. When you say, hey, I have them on a 50% high flow device, they're receiving 50%. And that FiO2 is not going to change no matter how the patient's breathing pattern may change. Maybe they breathe some shallow on a few breaths, some deeper breaths. Again, if I set it up correctly, will meet or exceed the patient's own inspiratory flow needs. The reservoir device, and I think they just ran out of graph here, else they would have put it over several breaths. The reservoir device, at least in this breath, does exceed the patient's own inspiratory flow needs. But if I just use the reservoir device and compare it to those other breaths, if I attempt to try to draw a straight line, look, with that breath, the device does provide a good chunk of the FiO2, but the patient does still breathe some room air in. Again, if I follow it, even for that breath. So notice here, not as many breaths, but that's why I would always group the reservoir under low flow devices. Because again, not as much like a low flow device, but there is still going to be some variable FiO2s here. So as we go through talking about low flow devices, and we'll get into the reservoir devices, Egan's, the textbook's definition of reservoir devices, I'm still going to group all of those and refer to those simply as low flow devices. Because again, the FiO2 can vary, All right, let's get into the devices. All right, the first one, nasal cannula. Not to be mixed up or confused with the high flow nasal cannula that we'll get into on Monday and talk about. You guys have seen a high flow cannula in operation? No? Some yes, some no. Don't worry, you will in time. But what I'm talking about here is not that type of cannula. This is just your standard low flow nasal cannula. Now, things you need to note, what FiO2 range can your standard regular low flow nasal cannula provide? Textbook definition says 24 to 40%. 40% being the top. We'll go over how to guesstimate what the FiO2 is being provided with a low flow nasal cannula. And you'll see based on that calculation, technically it's 44 that we can provide, FiO2 wise, 44. But I just want to share, the textbook says it's about 24 to 40. Remember, what's so unique about this FiO2? It can vary. Even though we'll learn the shortcut, you probably already know the shortcut to figure out what FiO2 is at the various liter flows, it's still variable. Again, patients start changing their breathing pattern, that FiO2 might not necessarily be what we think it is. Flow rates can be anywhere from 1/4 of a liter, now that's in the neonatal world, up to about 6 liters. Typical for an adult's about 1 to 6 liters is kind of standard for us. Infants, neonates, generally 2 liters or less, even down to just 1/4 of a liter. It's like, is anything even coming out of there? You can barely even feel it. But that variable FiO2 does depend on how much room air the patient breathes in addition to the oxygen that we're providing with the device. Humidifiers, bubble humidifiers specifically, can be added generally at 4 liters or higher. So anytime you have a patient with nasal cannula 4 liters or higher, it's a very nice idea, because sometimes the patient don't even know that's even a thing, to provide them a bubble humidifier. Now that being said, could you put a bubble humidifier on a patient wearing a nasal cannula if they're only on 2 liters? You can. You're not changing anything. You're just providing more moisture to the patient. And sometimes, and again, the patients generally don't know, unless they wear oxygen at home, they don't know about the bubble humidifiers. They don't know about the moisture that can be added. So if a patient complains of dryness, irritation, nose bleeding, that sort of thing, you can say, well, hold on, let me go grab a humidifier and let me add some moisture to it. And even though they may be on 1 or 2 liters, that may be enough to kind of keep them a little more comfortable. And I've had patients, the second I attach it, they tell me, man, that is a noticeable difference, you adding that humidifier to it. So again, 4 liters or greater, absolutely you better add one. But don't feel that you can't add it to a lower liter flow if the patient's complaining of dryness, irritation from that gas. Because when you think about it, if we're not using a humidifier, and what's coming out of that wall outlet is oxygen, and how much moisture is in that oxygen? Nothing. Nothing. There's no moisture in that oxygen coming out of that wall outlet. All right. We talk about how cold it is when it comes out from that liquid converted to a gas. Cold and dry. Very, very dry. So that's where the humidifier is always a nice thing to add. But only with the nasal cannula. There's other devices that you cannot add moisture to. It can mess up the device. All right, the rule of 4. The rule of 4. Now the textbook goes into a slight variation of this rule of 4, and I'm not prepared to change the way I teach it because nobody else is using that method right now. The method that's in the textbook only changes the FiO2 by 1%, so I don't think it's that big of a deal right now. Plus, it's still what? Variable. It's a variable depending on how the patient's breathing. But if we start with room air being, I know it's 21%, but if we start saying it's 20% oxygen in the room, for every liter you add simply 4 more percentage points. So 1 liter is a 24% FiO2, 2 liters is 28, 3 liters 32, and so forth. If we can go up to 6 liters, that's where I say, okay, that's where the 44 number comes from. But again, the FiO2 is variable, but at least it's kind of a good ballpark for us to say, you know, I wonder how much oxygen this patient's receiving right now when they're on, say, 4 liters. Okay, my rule of 4 on it, and I will sit there and go, okay, 24, 28, 32, okay, 36 is at 4 liters. All right, so make sure you do know this way, this method. Everybody comfortable to put on a nasal cannula on a patient? You are going to come across patients that have taken it off to get up and go use the restroom. They come back to the bed. They know the prongs go in their nose, and that's about it. And they'll put it on a certain way, and you walk into the room to give a breathing treatment or to do this or do that or check their oxygen, and you realize they're not wearing it right. You know, the prongs are curved, right? So don't curve them out, curve them in. But what some patients, not all, but what some patients will do, and they'll put it in their mouth, they'll put the prongs in their nose correctly. They'll put it here, and then they don't know where the rest of it goes, and they'll put it over their head and cinch it in the back. You know, and we walk in the room, and it's cinched in the back, almost ponytail-like, and you wonder, that doesn't look right. Something's unique about that. Oh, it's not even going over the ears. So when you put the prongs in, you can place them behind the ears. You can use this to kind of cinch it up a little bit so it doesn't move as much. I've had patients, let me fix that for you. And the second I do, they're like, no, I like to wear it like this because it bugs my ears. Okay, that's fine. As long as the prongs stay in your nose, that's the most important thing. If you're okay with it this way, now I think it would bug me when I would put my head back on the pillow because I would feel the tubing back here, but that's just me. If the patient's cool with that, I'm cool with that as well, as long as the prongs end up in their nose. Now I will say this, I've walked into patients' rooms, they have a prong in this nose and the other prong sticking out of the other, or vice versa. I mean, that happens. Okay, that's right. And they put it on and you happen to catch that. Okay, just fix it for them. Now somebody may say, you know, I kind of have a sore on this nostril and it kind of bothers me in there, that's why I have it like this. Okay, that's fine. But understand, their FiO2 delivered is probably going to be a little bit less than we anticipate if it's only in one nair and not both. So just things you'll encounter from our patients that wear the nasal cannula. But it's well tolerated, not overly uncomfortable. I can say that being somebody that doesn't have to wear it all the time, but you know, generally comfortable.
So when you're documenting it and they only have it in one nostril, like you just document whatever.
I probably won't go into that detail. It's only in there right near. Yeah, probably won't necessarily go into that detail. All right, another type of low flow oxygen system is a nasal catheter. A nasal catheter, a piece of oxygen tubing that actually goes into the nair, and notice how far back it goes. Almost all the way back to the uvula, providing free flowing oxygen. Okay, now let me ask you, you need oxygen. You have two options, the nasal cannula or a nasal catheter. Which one are you going to prefer? Yeah, keep that away from me. I can say it better myself. We tend to not see this that often. That's why I said the last bullet point, rarely used or rarely seen today. Again, because it does have to go back pretty far, kind of taped into position. You can see liter flows anywhere from 1/4 of a liter up to 5 liters. FiO2 range similar to the cannula, 22 to 45. Now, of course, it could stimulate a gag reflex from a patient. Maybe that's another reason why, as a patient, I wouldn't want to wear one of these. As opposed to a nasal cannula where there's a 1 centimeter prong just sticking into the nair. I've had students before go into the hospital and after clinicals come back and go, John, I saw a nasal catheter. I'm like, you did? Again, I don't say no, or you didn't. You did? Describe it to me. Did you follow the line that was in the patient's? And I'm not doubting they saw something in a patient's nose, right? Say, okay, when you see that, the next time you see that, follow the line and tell me where it goes. Does it go to an oxygen flow meter? If it does, then by God, you saw a nasal catheter. But did it go to something else? Oh, I didn't notice. I didn't look. Well, next time pay attention. So that's what I'm telling you guys. If you see something in someone's nose, and you will, follow the other end and tell me where it goes. If it goes to an oxygen flow meter, then what you are seeing is a nasal catheter. If it goes to something else, what are you most likely seeing? A nasogastric tube. That's going way further than just this. It's going down into the stomach. That's probably what you're seeing if you see something with a tube just down someone's nose. And a nasogastric tube is thin, small, like a nasal catheter would be. Again, very thin, very small, but very rarely would you ever see this.
Would you put like an indicator airway in to put that in? If you do see it, no,
No.
just be like,
It's not going in that far.
You said it's not going that far?
It's not going in that far that you would need lubrication.
But I mean, like, it wouldn't irritate, you know?
It's thinner than a nasopharyngeal airway, much thinner than a nasopharyngeal, or even a suction catheter. It's much thinner. So that's a low flow, another example of a low flow system. Another low flow system is the transtracheal oxygen catheter. A surgically placed Teflon catheter that gets placed through the second or third tracheal ring. Again, this is not a tracheostomy tube. This is simply an oxygen tube that is invasive, surgically placed between the second or third tracheal ring. Flow rates anywhere from 1/4 of a liter up to 4 liters. FiO2 ranges not quite as high as a nasal cannula or a nasal catheter, 22 to 35%. Does require careful maintenance and cleaning. Do you think it gets kind of junky? Again, because this thing ultimately doesn't end up like a nasal catheter, just there in the nasal passage. It's down actually sitting in the trachea. So do you think it gets kind of junky, congested sometimes with mucus? And if it gets blocked with mucus, then obviously it's not able to provide oxygen to the patient. That's probably the biggest troubleshooting issue with the transtracheal oxygen catheter, is if the patient doesn't keep it clean, it can easily get occluded, and now they're not receiving any oxygen. Even though the oxygen may be quote unquote freely flowing, it can't get past the mucus blocking it. You can kind of see what one looks like here. Here's a couple other pictures of people wearing this. Now notice I didn't use the term rarely seen today like I did with the nasal catheter. you're actually going to see people that have a transtracheal oxygen catheter. Now, why would somebody select this? When an option could be your standard nasal cannula, but yet they choose to select a transtracheal oxygen catheter. Again, invasive, surgical. When you say the word surgical, there's surgical risks always involved in any surgery, no matter how minor. Why would somebody choose this?
Compromised from some compromised, I guess.
Okay, that's
Like
that's not unheard of.
like
That's
trauma.
okay. Trauma. They probably have other issues to deal with than just this. But
I was gonna say they look normal, like the people that are wearing it doesn't
how
look
about
like
the
they have any.
and that's it. Their appearance. Their appearance. I'm not saying I agree with this. I'm not saying you have to agree with what I'm about to say. But there's some people that say, you know, this is a little less noticeable than if I have to walk around wearing your standard regular nasal cannula.
So it's
Now,
an option.
It's an option. It's an option. I'm not saying the patient has to select this one, but it's an option for those that, you know, I'm sick of wearing this cannula. I'm sick of every time I enter a public space, people are turning around looking at the nasal cannula on my nose. And I'm not saying that's how I would feel or that's how you would feel, but there's some folks that, you know, I like this because it's a little more discreet. If I was wearing one right now, I could button my top button and you'd probably never see it. Now you would see me wheel around this tank or this cart as the tubing's coming out back of my shirt. So, but as far as visually, a little less noticeable than say your standard nasal cannula. So you don't see these as often, but it's still possible. They are out there. So a patient could show up into your hospital and this is who needs home oxygen therapy, and this is their method of oxygen delivery. So it's possible you can encounter someone this way. Go ahead.
So it's like people who don't have like a stoma already. Like,
Right, yeah, they don't have a
not
trach.
use
They do not have a trach. There's someone like you or me that needs oxygen. They need home supplemental oxygen. And I don't mean they just need it for a couple of days. A couple of days, it's going to be the nasal cannula, trust me. But if they need this for the rest of their life or for a lengthy period of time perhaps, this may be something they choose instead of the noticeable nasal cannula. And I'm not saying that would be me, right? If I needed home oxygen, I'm going to say, give me the cannula. I'm fine. I don't care how I look to people. It is what it is. And if they don't like me, then that's their problem, not mine.
Do they have to change the catheter?
They
time
do.
and time? Like they,
Picture how
and that's,
mucousy the trachea can be, and it could easily occlude and block. That's why they're taught how to take it out, patient in the home, take it out, clean it, maintaining sterility, yes, because it is invasive. And so, but my thing is, you know, all these other complications that you have to follow with this. Some patients would agree with us and say, yeah, that's too much. Give me the cannula. I'm fine with that. But there's still others going, and I'm not saying that they're, lost the word I was going to say, but I'm not saying that they're all about themselves, but just they prefer this. Vain's a good way. I'm not saying that that's the way they feel, but you know, whatever to keep things off my face, yeah, I'll do whatever. And you'll teach me how to clean it? Yes. Okay, I'll do it. You'll teach me how to replace it, and I got to slide this thing out of my neck? Okay, I'll do that. There's people that are like that. They would prefer that way. I'm not saying that's me or you, but there's some that, and to be honest, it's nice to have options. You know, I'm not saying that this would be the option you would want or you would select or your loved one would select, but it is another option.
He over there smiling like he the spokesperson for the
Yeah, I'll talk shit right now.
That's right, that's right. All right, so dealing with low flow systems. Oxygen concentrations, as we've said before, delivered by low flow systems will vary depending on how much room air they pull in as the patient's breathing. That amount of air dilution that they're pulling in does depend on patient as well as equipment variables. So, things to think about, again, for low flow systems. If there's a higher liter flow of oxygen, obviously that's going to increase the delivered FiO2. If they close their mouth when they're breathing, picture your nasal cannula. If I'm breathing in through my mouth, maybe I'm in distress, I'm pulling in room air through my mouth because this is where the oxygen is, right? Tell the patient, close your mouth. Breathe in where the oxygen is. You know, if their saturations are kind of dipping a little bit and they're starting to panic, close your mouth. Breathe in through your nose. That's where the oxygen is. That's going to increase their FiO2. If their tidal volumes are lower, if their own inspiratory flows are lower, slower rate of breathing, slower minute ventilations, again, that's going to build up ultimately higher FiO2s. If they have a longer inspiratory time, again, they're breathing in oxygen. The longer that is, the higher the FiO2 will be. Again, that also equates to a higher IE ratio. The exact opposite is true for all of these others. Again, things that could decrease the FiO2. But again, patients breathing and the equipment itself, liter flows in particular, can affect oxygen delivery, oxygen concentration delivery.
How would the low tidal volume give them an increased FiO2, but also a long inspiratory time would increase the FiO2? It just kind of seems like it's
Because they're not having as much, with the smaller tidal volume, they're not having as much CO2.
outside air mixing in with it.
Correct, and that's what alters the FiO2 is, are you getting in more extra air or less extra air?
Yeah.
That can affect FiO2 concentration. So if their tidal volumes are smaller, they're not sucking in as much room air. They're not pulling in as much 21% to lower the delivered FiO2.
How would that work with the long inspiratory time? Because that just seems like it's counterintuitive.
Because they're breathing the oxygen. The oxygen is there. They spend more time breathing in that oxygen, that's going to increase their FiO2. Time breathing in that oxygen.
Is that not going to increase their minute ventilation or their tidal volume though?
Not necessarily, not necessarily. Again, that's just time spent in inspiration.
So would you try to coach your patient on how to the best method of breathing when you're using
Ideally, just breathe normal. Focus on breathing normal. Not too fast, not too slow, not too shallow, not too deep. Just normal, regular breathing. What I would say, and again, I'm going to use the MBRC phrasing here, to get the most ideal FiO2, and again, I'm still saying it could be variable, that's why they're low flow, they're variable FiO2s, but if you want your patient to receive close to the FiO2 you believe they're going to receive, they should have a quote-unquote ideal breathing pattern. Ideal breathing pattern. So here's the MBRC question. You have a patient that does not have an ideal breathing pattern. What device would you give that patient? Would you select a low flow device? They do not have an ideal breathing pattern. Or, again, variable FiO2 with a low flow, or would you prefer a high flow device that will provide a fixed FiO2 for those patients with a variable breathing pattern? In that case, pick a high flow device, because it doesn't matter how their breathing pattern is going to be. They will get the delivered FiO2. So sometimes the MBRC can ask, okay, what device are you going to pick? And they might not necessarily classify it high flow, low flow. They give you device options: nasal cannula, simple mask, non-rebreather, Venturi mask. You know, and you have to find out, okay, of those, which one's high flow versus which one's low flow. And we'll get into all that by the time we finish up through this chapter today, and then on Monday. All right, so troubleshooting some low flow devices here. Inaccurate flows. Again, so very important to remember what the liter flows are for these devices. What the ranges are supposed to be. System leaks or obstructions can occur, sometimes from mucus, obstructing the catheter if it's a transtracheal oxygen catheter, etc. device displacement. I think we kind of mentioned that with the cannula getting just in one there, or you walk in the room and it's on the patient's forehead. And I get it. I guess I would get tired or irritated of that too. And sometimes the patients just need a break and they'll put it up here, like they're putting their sunglasses on their forehead. You know, they just pop it up here, then forget about it. We walk in the room. Thanks. We forget about it, and they walk into the room, and like, here, let's put you see their O2 sats are kind of borderline. Okay, let's put your oxygen back on. Your oxygen saturations are kind of falling. And then skin irritation, typically from around the ears. You know, cotton balls, gauze, things like that to provide some padding. They do make these padded pieces that can slide over the oxygen tubing. I'm not saying every single hospital has those, but if they do, and you have a patient that's really red or irritated or complaining about their ears being very raw, if your hospital has those, real simple, they will love you to death. Your patients will, if you can pop one of those on there and just make it a little more comfortable. But you may walk in the room and wonder, what the heck is this guy doing? Again, just to try to keep that tubing from rubbing on the ears. Again, for device displacement, again, like for the nasal cannula, because you can kind of cinch it up under the skin, not tight. Don't make it uncomfortable where it's cutting into the skin. But again, if it's loose, it's more probable that the device could come out of the nose, come out of the nostril. But if you can kind of cinch it up a little bit, it can make it kind of hold its position a little bit better. All right, moving into reservoir systems. Again, using the text breakdown of these things. Reservoir and systems incorporate a mechanism for gathering and storing oxygen between a patient's breath. And patients will pull in from this reservoir of oxygen. Whenever their inspiratory flow exceeds the oxygen flow from the device. Now, these systems tend to provide FiO2s that are higher in concentration, but still, like I said before, the FiO2 could still be variable with the patient's breathing pattern that's a little off, a little not normal. All right, so the reservoir cannulas, okay, not to be confused with the nasal cannula, your standard nasal cannula, but reservoir cannulas. They're designed to conserve oxygen, and they can reduce oxygen usage by as much as 50 to 75%. And I'll kind of show you something in a minute that kind of displays that. Maybe this is something for a patient in the home, so they don't use their oxygen as fast with the standard nasal cannula, if they're using maybe a reservoir cannula. Now, examples of the nasal reservoir and pendant reservoir cannulas. The term oxymizer is a brand name that sometimes the device will be referred to simply as the oxymizer as opposed to a nasal or pendant reservoir cannula. But the word oxymizer is a brand name. Now, generally, flow rates are usually pretty low with these, and lower FiO2 ranges, of course, as well. Humidification, very important to note with this. Humidification is not necessary with the reservoir cannula. And if you were to add moisture to the reservoir cannula, you can cause those valves that will move back and forth to help to conserve oxygen. You will cause them to stick if you add moisture via humidity to it. So never, never, never add a bubble humidifier to a reservoir cannula.
Is there like a high flow version of an oxymizer? Because I'm pretty sure I've seen a patient on like 9 liters oxymizer or something.
And you probably will. You probably will. Technically, that's not where the reservoir cannulas were intended to go, to those liter flows. But I know we do sometimes use those when we need a higher oxygen concentration and I have no other options available to me. The masks are all ruled out because the patient can't handle the mask. And so there's something else we can try. I want to say we use these similar to how we use the high flow cannula today before we even had high flow cannulas. But generally they're meant to conserve oxygen so we're not running them at excessive liter flows.
Maybe we were out of high flow devices.
And maybe, or there's only so many to go around, right? All right, so there's the two examples. On your left here is the reservoir cannula, the pendant cannula here. These obviously, if you haven't had a chance to see them yet, these are much larger than your standard cannula. And some people call them a mustache cannula. I've heard people call them a walrus cannula because it's big and bulky. if you're a little offended by the appearance of a standard cannula as a patient, you're not gonna like this, because it's much larger in size and really stands out at a distance that you're wearing something. But, and I don't know if you can see the kind of slits in here, there are some one-way valves in here that will use this to conserve oxygen prior to the next breath. So when I said if you use, God bless you, if you use humidity or moisture, it causes those valves to stick and could affect the ability of oxygen to be conserved in that reservoir. The pendant cannula, the conservation of oxygen is here in the pendant itself. These things, the pendant cannula, this tubing is thicker than your standard nasal cannula. There's tubing that goes around the ears. It is big, it is bulky. This is bulky right here under my nose, but this is bulky overall. And then the pendant, the part that's here, that's pulling down, I think your ears get rubbed raw with your standard cannula. I can only imagine you see something like this when the tubing's even thicker.
It's a lot less pliable too.
It definitely is, definitely is. All right, so remember I said these are used to help to conserve oxygen. I'm not going to ask any of these numbers, so don't worry about trying to memorize these numbers or anything like that. But what this company's claim is these reservoir cannulas can conserve oxygen. So if your oxygen requirement with your standard nasal cannula is 2 liters, that's what you need with your standard cannula, you can wear the oximizer or reservoir cannula and run it at 0.5 liters and get the same FiO2 effects. Meaning you're conserving 75% of your oxygen because you're only running it at a half liter as opposed to 2. And that's where you're saving your oxygen. Now, the higher the liter flow, the less savings, but for example, I'm just gonna jump down. 5-liter standard cannula, you can run the reservoir cannula at 2.5, saving 50% of your oxygen. Your tank's gonna last a whole lot longer running at 2.5 than say you ran it at 5. And that's the purpose of the oximizer or reservoir cannulas, to help conserve oxygen.
So why wouldn't we use the oximizer on everybody? Is just a cost thing?
Cost, they're a little bit more expensive than your standard cannula. You know, oximizer, reservoir cannula that costs $5 for one, nasal cannula costs $0.25 for one.
Yeah. But like anyone who is wearing a cannula, they could also wear an oximizer at these appropriate.
At these appropriate liter flows. If it takes this much on your standard cannula, it's going to take about half of that for the reservoir cannula.
And there wouldn't be any downside besides the cost and the
Cost
appearance.
and the appearance. Appearance gets to most people. You come in here with, okay, let's take you off this little nasal cannula and put this big mustache. It could be, or that could be a high flow. The high flows today, there's so many types that it's hard to identify the different types because it's just all different brands. All right, so that was the reservoir cannulas, the mustache style or the pendant style. The masks, again, the textbook does group these under the reservoir type devices. I would still follow this. These are all not high flow, and the 3 primary types: simple mask, partial, and non-rebreathers. All right, let's start with the simple mask. Know the liter flow range for a simple mask. 5 to 10 liters is appropriate, but 5 liters has to be the bare minimum. You can't run it at 2, you can't run it at 3, you can't run it at 4. 5 liters has to be the bare minimum, because at 5 liters, and again, remember 5 liters is coming through here, at 5 liters will wash out the excess carbon dioxide that the patient exhaled. If I provide liter flows less than 5, it's not enough flow to wash out the exhaled CO2. Now, and this is no offense to any other profession, but they don't get the level of instruction we do when it comes to respiratory and the devices like we're talking about today. I was called to a patient's room one day. The patient was desatting, and the nurse was wanting the therapist to take a look at the patient, and it was my patient. It was my floor, so it ended up being my patient now. And so I go to take a look at the patient. The patient was wearing a simple mask. The simple mask was running at 2 liters a minute. 2 liters. They were retaining CO2. No wonder they were desatting and were complaining of shortness of breath. So what did I do? I immediately bumped it up to 5. All right, minimum 5. And then in talking with the nurse, come to find out this is what happened. And again, this is no offense because other professions get various levels of training in our devices. Patient was wearing a 2-liter nasal cannula. The nurse, what she knew about O2 devices was nasal cannula could provide a certain FiO2 range, generally on the lower end of the spectrum. A simple mask was kind of somewhere in the middle. The rebreathers were a little bit on the higher end of the spectrum. So that's all she really brought to the table when it came to O2 devices. So she took the patient off the nasal cannula and put them on the simple mask, thinking she was providing a higher FiO2. She left the patient still at 2 liters. Her thought process made sense. It can provide a higher oxygen concentration if it's set up correctly, right? And so my thing was, why is the patient only on 2 liters? Well, they were on a 2-liter cannula. Okay, well, patient needs more oxygen. 2 liters can go to 3 liters, can go to 4 liters, can go up to 6 liters. That's one way to increase FiO2. But if you wanted to transition to something like this, then the minimum liter flow has to be 5. And so at 5 liters, that's an approximate FiO2 of 35%. At 10 liters, that's an approximate FiO2 of 50%. Some liter flow somewhere in between, go ahead and give yourself an FiO2 somewhere in between. All right? So, simple masks. We have so many, as you can tell, we have so many oxygen devices that are available to us. Some are popular, some not as popular. This is probably one that's not quite as popular as it used to be back in the day. We have so many devices to select from. This is probably one that a lot of folks don't have experience in using. It may be in the cart, it may be in the drawer, it may be in the box of different devices, but it's probably one that's going to be selected kind of last, toward the end. Not that there's anything wrong with it, there's probably just higher FiO2s, or I'll say some better devices that are out there as opposed to the simple mask. But because the patient can still breathe in through these ports, again, they're still pulling in room air. So that's why I'm never going to call this a high flow device, because again, variable FiO2. By definition, that fits the low flow device category. And so that's why I will still say this is a low flow device, even though the textbook uses this as a reservoir device.
Okay, just ask you
Yes.
one thing. Clinical with Jasmine, he says it's like 5 to 12, so.
And that's okay. A little bit higher liter flow is not bad.
Okay.
10 is what this textbook happened to use, so that's why I use 10. And you will find other textbooks may use slightly different liter flows, but we all agree.
I just want to.
Yeah, that's fine, that's fine.
To answer one thing here and there, and then.
Yep.
get
But
it.
we all agree 5 is the bare minimum. 5 is the bare minimum.
But if they ask it on the test, like what is the, flow range for a simple mask, and it says 5 to 10 or 5 to 12, which one?
Yeah, you're not going to get both of those as options, because again, it gets to be a little debatable on which one it is.
Okay.
But you will get 3 to 12, 5 to 10, 7 to 15 answer options. So I mean, there's enough variability that you can see. Okay, there's only one that really fits the bracket, the acceptable range there. But thank you for asking that. I'm glad you did. All right, one thing again about the simple mask, there is no bag on the end of the mask, right? The rebreathers have the bag, simple mask does not. Also, I'm gonna bounce back a picture here. Those ports that the patient exhales from, okay? Notice how they're kind of dotted. That's a simple mask. Notice the connection here, small bore oxygen tubing. Not to confuse the simple mask with an aerosol mask. People get these flip-flopped all the time. This is an aerosol mask. Now notice where the patient exhales through. Simple mask, they're more dotted. Aerosol mask, it's wide open. small bore oxygen tubing here, what would connect here? Large bore tubing. This is an aerosol mask. So don't call it a simple mask on the test. Don't call that an aerosol mask. That's a simple mask, that's an aerosol mask. Why do I say this? I get students all the time getting them backwards, mixing them up. And I can kind of tell why, right? But they're two different type of masks with two different names. All right, let's talk about the rebreathers. Both types, non-rebreather, partial rebreather, are both similar. They both actually come in the same package. You can make one or make it the other, just depending on how you design the mask or the device itself. It does have a collapsible 1 liter bag that's on the end. That's true with a non-rebreather, it's true with the partial rebreather. The patient will breathe in from the bag. All right, the patient will breathe in from the bag. The contents of the bag, which, again, you have oxygen tubing going to the bag, filling this bag with oxygen. So they are breathing from this bag. But the difference between the two is the use of the valves, the one-way valves. So, partial rebreather has 0 one-way valves. When you open these up brand new from the package, they're more than likely going to have the valves attached. To make it a partial rebreather, you have to physically remove the valves. You have to take the valves off. So there are no one-way valves. Notice there's no one-way valve here, there's no one-way valve here, there is no one-way valve here. They've all been removed. Liter flow minimum, 10 liters. Now if you see some ranges 10 to 15, 12 to 15, that's okay. Minimum is 10. But instead of getting hung up on a specific number, here's another way to look at it. Give enough flow so this bag does not completely deflate when the patient inspires. It's okay if the bag goes down a little bit, if it collapses down somewhat, but it should not completely collapse. Because if it does, they've removed all the gas from the bag and now they're pulling in more room air. So it's okay if the bag collapses a little bit, but it should not completely collapse. If it completely collapses, what do you do to the flow? Increase it. Give them more flow. FiO2 range for a partial rebreather is about 40 to 70%. So we're getting to the higher end of the spectrum when it comes to FiO2. If we say, well, what about the non-rebreather? The non-rebreather has the one-way valves attached. There's a one-way valve here, there's a one-way valve here. Now, so there's 2 on my picture, but by definition, a true, God-honest, true non-rebreather should have 3 one-way valves, which means if all 3 one-way valves are attached, the patient could not be able to pull in any room air. When they inspire from the bag, this one-way valve pops open, lets them breathe the contents of the bag. Now, by definition, if they're breathing in only the contents of the bag and they're not pulling any room air, then by that definition, to me, that sounds like a high flow device. But what you're going to find on most non-rebreathers, instead of having 3 one-way valves, you're going to see 2 one-way valves. Definitely a one-way valve between the bag and the mask, and a one-way valve at least on one of these ends, with the other end completely left open. Now when the patient inspires, they still inspire the contents of the bag. This one-way valve opens, this one-way valve closes, so they can't pull in anything from this side. But with this side left open, they are still able to pull in some room air. And that's going to mix and dilute the delivered oxygen. It's why your FiO2 range is only around 60 to 80%. And you've heard me, I said at the beginning of this class, what if they're on 100% non-rebreather? Okay, and you'll hear us talk about that. You'll hear the respiratory therapists talk about that in clinicals. Oh, they're on 100%, they're on the non-rebreather. In theory, that's what they're on, but just recognize they're probably not going to be able to be on that high of an FiO2 100%, especially with this side open. They are pulling in some room air. But in theory, this device is probably the device that can provide the highest oxygen concentration that we have, minus the high flow nasal cannulas. Liter flow is still the same with a non-rebreather as it is with a partial rebreather. At least 10 or enough to make sure the bag stays inflated. It doesn't completely deflate during inspiration. If it does completely deflate, increase the flow to that bag. Plus, another thing about the mask, even though the mask may be on the patient and the straps are around the patient's face, they could still, it's not like an ambu mask or resuscitation mask where there's no air leaking in. So there's still going to be air leaking around the side of the mask. Again, that's why we're not going to quite get up to 100%. But that range, still remember that range, about 60 to 80%. Again, the tighter I put this mask on, if I can add that third one-way valve, we're probably bumping up the FiO2 a little bit higher than here, maybe up into the 90 percentile range. But it's not in a completely enclosed system like it would be if I had a resuscitation mask. Questions on the partial versus non-rebreathers? All right, again, you can see her one-way valve here, one-way valve here, and notice this side, nothing on that, that's open. But a true non-rebreather would have the 3 one-way valves.
And those we pop out if we need it?
Yes. When you get to the package that, okay, here's the rebreathers, and it may call it a rebreather, or it may even say non-rebreather on the package itself. When you open it up, they will have the valves attached. Again, in a perfect world, 3, but generally it's just 2. To make that a partial rebreather, you have to take the valves off. And what I would do is I take the valves off, and I'm not going to save them. They're going to get lost anyways, and throw those in the trash, and there's our partial rebreather. If later we needed a little bit higher FiO2 for that particular patient, if I had the one with valves still, I could put them back on, or I can just get a new one, leave the valves on, and place it on the patient.
Is that why, so yesterday when we were doing our little clinical thing where she chose to get a non-breather, but on the package it said 3-in-1, is that because it has those removable?
Yes, and 3-in-1, it can do 3 things. You can pop the bag off, comes with an adapter, you can pop it back on, remove the valves here, turns into a simple mask. So there's your 3-in-1 that you can get these things with, depending on the brand, depending on what the hospital purchases. Any questions on the rebreathers?
I thought the non-rebreather was a high flow.
And to be fair, we can debate it back and forth. If the one-way valves are attached and the mask is snug, and the only thing the patient is able to breathe from is the contents of this bag, then by definition, that's a high flow device. By definition, it's a high flow device. But because it generally only has the 2 one-way valves, the patient is able to pull some room air in through here. Right away, that makes it now low flow device. And because these masks are not perfectly snug, tight fitting like a resuscitation mask, the patient still could potentially pull some room air into that mask, which again, by definition, makes it low flow.
Okay, well, I'm gonna not take that in. Because Desmond literally said that that's gonna be, it's a high flow for our.
Right,
test
and
for
I get it, but we can debate it back and forth.
I don't wanna be part of it.
You know, that's gonna be question 1 on the test, right? I purposely don't put that question on the test because it's debatable, right? We can debate it back and forth. And we can take both sides of the spectrum and both be right.
Yeah.
Okay? So don't worry, I'm not gonna put that question, is a non-rebreather, or what type of device is a non-rebreather? High flow, low flow, blah, blah, blah. My made up names.
Instead you'll put, what is this non-rebreather with all
Yeah,
valves?
I wouldn't do that. I wouldn't do that. But yes, but it can be debatable, right? And there's going to be people that are going to be on either side of the fence, and you can't talk them, you can't convince them otherwise.
Okay.
I'm right in the middle, going, yeah, I can see your point. I can see your point.
And it's staying on my foot.
And I'm gonna, and that's why I'm giving you both points. I'm gonna give you both examples here that yes, we could classify this non-rebreather and we could be correct. We can say, okay, but if it's not attached here, whatever, it could be a low flow device, and I can agree with that person as well. But I am not going to ask a question about, is a non-rebreather a low flow or high flow device? And I'm not going to ask that question because, again, it could be debatable. If I ask that question on the test, you said low flow, you said high flow, you're both correct, right? You're both going to be right. But I purposely am not going to ask that question on the test.
Okay.
But those that are most passionate are going to be on that high flow side. And I can understand, but I could easily say, yeah, but it could be a low flow device if this and this. But anyways, not worth the fight, not worth the argument. All right, troubleshooting these reservoir systems, whether it's a simple mask or the partial rebreathers. Device displacement. These things could be cinched up pretty snug, but it also can be pulled where it's loose. I'll walk into patients' rooms with a mask, and the mask is down here. Buddy, that's not doing you much good. I know, it's just kind of bugging my nose and stuff. All right, well, let's try to get it back on here a little bit. These things, even though they're not going over the ears, they could rub the ears, they could rub the side of the head. Again, here's another gentleman here with some gauze or some tape. System leaks, obstructions, inadequate flow. Again, that's a very common MBRC question. To describe one of the rebreather masks and paint this whole picture, this whole scenario, but they have a rebreather mask and the bag completely collapses during inspiration. What do? Increase the flow. Increase the flow to the device because the bag should not completely collapse during inspiration. Skin irritation we can see here. And how about claustrophobia? There's going to be patients that they're okay with a cannula of various sorts. Even the reservoir cannula, they're fine with. Yeah, it may look a little funny, but they're fine with it. But the second you take that off and you say, nope, you need a mask and fill in the type of mask, like I can't handle that. You know, that's an issue for patients who have claustrophobia issues. And a mask won't be appropriate. This gentleman not only has skin irritation here, but even on the bridge of his nose. Again, these metal pieces, these metal clips over the bridge of the nose can help kind of hold it, tighten it into position. But these masks are pretty pliable. Also, when you do, is this my last slide?
Yeah.
Okay. So I can talk about this now. When you put any mask on a patient, what's this material? Anybody have a clue? It's elastic. It's an elastic material. I've had students, and I hate to share the bad stories of what's happened to a student in the past, but I share this so you don't make the same mistake. Okay, you can see how the mask can be over this patient's face, right? Straps going around. I don't like to lay them this low so it's rubbing on the ears. You know, it can be up a little bit higher and just be around the head. I had a student, again, and you think about it. Again, let's say today I give you this and say, here, put this on a patient. How would you put this on a patient? Would you put the straps around the head and then put the mask on? Would you put the mask on, then put the straps around the head? Again, who knows the sequence you would do when I hand you this and you walk into a room, right? You just did it. I had a patient put the straps around the patient's head. The mask is out here. The mask slipped out of their hand. That's elastic, right? The mask is out here, slipped out of their hand. Where'd the mask go? Pow! Pow! Right into the patient's face. And I would hate for that to happen to you, to cause that to a patient. I can laugh now. At the time, I wasn't very pleased with the student who did that, going, what were you thinking? Put the mask on, make sure the mask, and then just slide the straps over. Piece of cake. If it's a little loose, then you can kind of cinch up and tighten them up a little bit. But be careful, you put the straps around their head and then hold the mask and you let it go. Those straps are elastic, that mask is pow. It's going right back at the patient's face. So I don't want that to happen to one of you guys, right? Yeah, don't give me a story to tell years down the road. All right, so some questions for y'all today. And there's several today. All right.
You want an apple? Here's an apple.
So, first question, which of the following is not a goal or clinical objective of oxygen therapy? Let me read them. Is it A, decrease symptoms associated with chronic hypoxemia? Is it B, prevent hypoxemic-induced multiple system failure? C, decrease the workload hypoxemia imposes on the cardiopulmonary system? Or D, correct documented or suspected acute hypoxemia? Which one is not a goal? B. B is not one of the goals. Prevent hypoxemic induced multiple system failure.
All right.
Sounds kind of nice, but no, that's not a goal or objective of oxygen therapy.
All right, I'm placing my wager. C.
Okay, next question. Name the device. So it's either a nasal cannula, simple mask, partial rebreather, non-rebreather, transtracheal catheter, or reservoir cannula. Now let's look at the mask. Does the mask have a bag? Yes. And I know it's difficult to see the picture. There is no one-way valve here. There is no one-way valve here.
Damn right.
Nor is there one here. What does that make it? A partial rebreather. Partial rebreather.
What did I say?
You said C. All right, so this is a partial rebreather. On the test, I am going to have some pictures that you're going to have to identify similar to this. Now, in something like this, that it may be a little bit difficult to see the valves, in the question, I would say name the following device. Note there are no one-way valves, and I would leave it alone there. Or there are one-way valves, and give you that picture. But the picture, I'm not going to say that there's a bag or not a bag. You should be able to tell that there's a bag there or not. All right, next question. What is it? This is the reservoir cannula. If the patient doesn't like something big and bulky on their face, if they have trouble finding the appearance of a standard cannula, so I say reservoir cannula, they're not going to like that at all. Look how big that is, how big that mustache-looking piece is. All right, so this was F, a reservoir cannula. Next picture. I'm not going to say anything about one-way valves or not. Okay. All right, so mask, small bore oxygen tubing, no bag. So this is a simple mask. This is a simple mask.
That mask literally makes me think of Gonzo every time I see it.
Okay.
I don't.
All right, next question.
The Muppets.
There is a bag. And can you see that one way, at least on the side, see that one-way valve? There is a one-way valve between the bag and the mask as well. So this then is a non-rebreather. This is a non-rebreather.
So there will always be a one-way valve between the bag itself and the
Yes.
mask?
Now, as far as the potential 2 one-way valves instead of 3 that you're going to see, there's always going to be a one-way valve between the bag and the mask. There's generally just going to be one on the side, whether it's this side or the opposing side. And these things are really easy just to grab hold of and peel right off. Just switch a non-rebreather to a partial rebreather. What do you think that is? He didn't consent to the picture. So what is it? What do we say it is? Of these options?
Reservoir.
It's a reservoir cannula. What, and I didn't ask this, but what type of reservoir cannula? The pendant style reservoir cannula. There you can see the pendant piece here. If you didn't see that, you look at that and go, that's a regular nasal cannula, right? But the pendant part. So it's a reservoir cannula. Reservoir cannula. He's happy. He's happy wearing his oxygen, right? See, they tend to be happy when they're wearing their transtracheal oxygen catheter, right? All right, so this is transtracheal. Yeah, I went to the company that does these to find some pictures. And of course, yeah, everybody's happy, everybody's smiling, everybody's doing good. I guess it wouldn't be good marketing if the patient wasn't smiling or wasn't happy, looking miserable. All right, transtracheal oxygen catheter.
I went to surgery for this.
Yeah, hardest one of the bunch. Okay. Simple mask, right? Simple mask. Nasal cannula, standard nasal cannula. Now, when we get to the high flow cannulas, sometimes you're going to need to see a little bit more. Okay, I see the cannula portion, but what's it connected to? You may need to be able to see some more stuff to say truly that's a high flow cannula. But based on this and this alone, let's call this a standard nasal cannula, low flow nasal cannula. Any questions? Any questions? So the test next week, which is on Wednesday, we still have part 2 to talk about on Monday, but the test next week, Wednesday, like I said, there will be some pictures of, and let me think, what's the test over? Oh yeah, the test is going to be over the devices, the aerosol devices, MDIs, DPIs, so you can have pictures of the different type of DPIs especially. Wanting to know the FlexHaler